If you value nutrition and you're with your patient and you've got 15 minutes, always start with a question. How important is your diet? Don't ever assume that someone in a larger body is eating a lot more convenience food and soda than someone in a smaller body, because it's not always true.
Hello, everyone, and welcome back to the podcast for doctors by doctors, put on by Panacea Financial. I am so happy to have two guests with me here in the studio today. We're going to be talking about round two in our series on ultra-processed foods, health, nutrition, the mind-body-gut integration, and everything that you can be doing as a clinician to be providing better information to your patients on how they make nutritional decisions every single day. I'm thrilled to be here today with my guests, Anafer Barrera and Dr. Gerald Cox. Anafer is a registered dietitian nutritionist and master of public health in health education and behavioral sciences, a certified intuitive eating counselor, certified body trust provider, and certified mindful self-compassion healthcare provider. She's passionate about helping people heal their relationship with food, body through compassionate, evidence-based care. Drawing from both professional expertise and her own experience overcoming disordered eating, body image struggles, and health anxiety, Anafer empowers others to build sustainable health, reconnect with their bodies, and find lasting freedom from their diet cycle. Anafer, welcome to the podcast for doctors. It's really great to have you here.
Thank you. I'm so excited.
I'm extra glad to be back with Dr. Gerald Cox now for our third time overall, second time on this particular topic, but reintroducing the one and only Dr. Gerald Cox, a physician, educator, and entrepreneur dedicated to preventing and reversing cardiometabolic disease. As a specialist in preventative medicine, obesity medicine, lifestyle medicine, internal medicine, and artificial intelligence, Dr. Cox has built his career around the future of preventative care by asking a simple but powerful question: how do we help people live longer, healthier lives? He serves as an associate professor at Loma Linda University and is the co-founder of Mirror Health and Wellness, where his work focuses on improving patient outcomes, advancing population health, and building better systems of care for some of healthcare's most pressing challenges. Dr. Cox, welcome back. It's great to have you.
Great to see you, Dr. Palmer.
I am amazed and thrilled to have both of you here today. I think reading through your intros, I'm the least qualified person to be here. I have the least number of certifications overall. Dr. Cox and I had joked around about last time. I'd never seen somebody with more letters after his name. I think Anafer's giving you a run for your money, though, and I really appreciate that.
As she should. I think I'm going to have to look. I'm going to work alongside Anafer when it comes to treating some patient populations.
I absolutely love it. So we are back talking about our series on ultra-processed foods here, right? And what we as clinicians can all be doing about it. I think that was why we were so excited, Dr. Cox and I, after our first session, to be bringing in a specialist like Anafer, somebody who can really talk us through coaching at the bedside when it comes to nutrition, health, that body image that, frankly, we as physicians either don't receive any training in or often shy away from because it's something that's not really baked into our curriculum at all. To date, just for some numbers, there's only 5 medical schools that actually provide required nutrition education above and beyond what is mandated by the USMLEs. It's growing. That number was 0 just a couple of years ago, but that's pretty low out of the 183 med schools based in the US. So, we've known for years that ultra-processed foods have dominated the Western diet. Recent literature has really shifted that conversation, though. And last time we spent a lot of time on the academics behind it. That we're not just talking about calories anymore. We're also talking about the commercial determinants of health that go and are tied into the social determinants of health. So we talked a lot about the American Journal of Public Health last time and how ultra-processed foods can be linked to millions of deaths globally, a lot of morbidity on top of the mortality when it comes to mental health outcomes. So let's just dive right into the questions. Dr. Cox, since our series last time, I'm going to start with you. How do you want to frame your own approach to ultra-processed foods and how you approach this conversation with your clients as an obesity and lifestyle medicine doctor?
I think that when I'm talking to my patients, the hardest thing is really just trying to create the atmosphere around the topic. And one of the easiest ways that I have found to kind of create that is there's almost this elephant in the room publicly and in the clinical encounter, where we understand that food has a little bit more of a bigger role than just us choosing what we're going to have for breakfast, lunch, and dinner. We know that when we leave from work, I often make this joke. Yeah, if I skip my breakfast and then I have a really little lunch, then I'm leaving work and then I'm passing Chick-fil-A, and then I'm thinking like, oh, I got to get some of those tenders in a chocolate shake. And what I try to do is I try to break down the idea that, food has a psychological component to it. And I get a lot of approved discussions from the patients, because you want to make sure, I like to make sure that they are giving me permission to have this discussion with them. And so when we start to talk about the psychological components of food, how these foods can become a bit more addicting and more behavioral rather than us actually seeking substance and calories to sustain our bodies, I kind of use that as that, like dipping my toe in the water and opening up the discussion a little bit more about ultra processed foods and how we can try to minimize that.
Anafer, I mean, similar question, how do you structure these conversations with your clients around food being so integrated into life, wellness, mental health, physical health? Like what's your in that begins the conversation so then you can start to form that clinical relationship with them?
Yeah. And if you don't mind, I actually want to say a couple things first, and then I'll go into how I talk about it with my clients. But first of all, I'm really, really grateful that physicians are talking about this amongst themselves. I love, like Ned and I talk all the time about controversial things, and especially when it comes to medicine and sciences and lifestyle. And he's good at admitting what he doesn't know and when he doesn't know something. So he started off saying, physicians really don't get a lot of education on nutrition. And what would the world be like if they did? And it's hard to say, because I thought I knew it all within my first nutrition course, right? Like my first course, I read my textbook cover to cover, and I passed with flying colors. It was my favorite topic. And that's when I decided to be a dietitian. But I really knew very little. I knew the top of the iceberg, and the dangers are underneath that, right? So who's to say, if physicians get more training on nutrition, what that would cause, right? Hopefully they start to rely on their dietitians a little more because they know what they don't know, or they decide that this is the field that they want to study, and then they pivot, and now they're this mastermind of two areas, right? The medicine and the lifestyle. But I really, really appreciate that these conversations are coming up. And me personally, as you heard in my credentials and all the certificates that I got when I graduated as a dietitian, I really see that psychological component of why we eat what we eat. So when I approach a patient, or when I was in a private practice, a client, first and foremost, and what I would like to really drive home for physicians is you want to approach them without judgment. And to not have judgment, you kind of have to really educate yourself about all these external factors when it comes to how we choose our food, right? Like our socioeconomic status, if we live in a food desert, if we had trauma from childhood where, someone was always telling me what to eat, and so now my autonomy helps me choose differently. So many factors can influence why a person eats the way they do, or why they have the weight that they have. So first and foremost, non-judgment with your patients. And then second of all, I always kind of go in with an assumption that they're trying their hardest, even if they're eating a bunch of packaged foods, or in a larger body, or skipping a bunch of food, right? Like skipping multiple meals. I think that they're doing the best they can with what they have been educated or provided. So with that, it's just, I guess it's different for every patient. It's really hard to simplify the question of how do you approach your patients. It really depends on what are they here for? Let's say you're a 22-year-old hospitalized for your uncontrolled type 1 diabetes, and you're just eating out of control. You're eating all the packaged foods. You're not monitoring your blood sugars. So how would I approach this patient? I want to ask, tell me what you've tried in the past. This has got to be very hard for you. Tell me about your diet. Well, I know I shouldn't be eating fried chicken sandwiches, 3 of them for breakfast, and it's oh, you actually can eat your fried chicken sandwiches, but look what it does to your blood sugars, right? To have 3 at once. So can we space them out? Or if you take your insulin here, right? So it's kind of you don't want to think that they have a lack of knowledge. You want to think maybe they have all the knowledge, but their beliefs might be causing some distortion in how they eat. And so therefore, listen to what they've tried and then either refer out, right? Or see if you can be like, yeah, that's super valid, but what if you switched it this way so that your medications can make it more easy for you?
I love that framework right off the top. I also think it's really fair to say that Anafer and I work together. I'm a hospitalist. I'm a MedPeds hospitalist. Anafer is a dietitian at the hospital. We work together. So we do have some shared clinical context just for our listeners joining us. But I love what you're describing there of like, to me, like if I were to put a word on it, you're approaching it immediately from a place of empathy. And I think in diet, much like, last time we spent a lot of time talking about kind of like the overlaps between diet and addiction and how, frankly, unfortunately, from a clinical standpoint, for a long time, those were like deeply judgmentally treated illnesses. And what I'm really excited about with the Lancet the Lancet tome, a year ago, and then the American Journal of Public Health, similar tome from just 2 months ago, is it really, I think, changes the mentality of clinicians around why this is happening, right? Food is seen as a distinctly like personal choice. And I think I've grown to completely disagree with that through like the science and data that's being presented in front of us. Like humans are making rational choices to them in that moment. Why are they eating all ultra processed foods? Probably the cheapest way to get enough calories in a day, probably the fastest, probably something that gives them some emotional high or even a dopamine surge, as we learned about the flavor engineering, right? All of these things are playing into it. And I think it immediately takes the judgment out of the room and it leaves that space for empathy. So you can walk in and approach that patient or that client, just like you described, and say like, you're doing your best. And I think that's such like a valuable framework to approach it from, like we would with infections, autoimmune diseases, like anything else. You rarely walk into in the middle of an asthma exacerbation and go like, well, what were you doing breathing air this week? Like, in the middle of wildfires. So but again, diet and addiction, unfortunately, breed this kind of mentality amongst clinicians. And so I love the idea of approaching that more from that space of empathy. Dr. Cox, I would love to hear kind of your thoughts and your approach on that. How do you inject that empathy? And then how are you kind of taking this information from the Lancet, from the American Journal of Public Health, and using it to kind of create like a broader space for your patients?
Well, I love that Anafer is really speaking to what is really an area of focus these days when it comes to treating obesity. The Obesity Medical Association and Bariatrics Associations, we're really trying to focus on the patient and their backgrounds and also looking at the clinician and their backgrounds, right? Because a lot of times we bring that hidden bias into the exam room, right? And so Anafer and I were chatting a little bit before we got started on this podcast, and we were talking about how, in 2020, there was this real influx of trying to understand hidden biases within the art of medicine. And I think that had its peak maybe around 22, 23. But I think that what I'm hearing from her and what I really would like to emphasize is trying to bring that back, right? I mean, if we look at what we look internally and we say like, oh, well, I don't have a problem with food. I make the right choices. Why aren't you making the right choices? Then we kind of have that bias towards that individual, like they're not doing enough. And those patients feel that, right? I mean, when you feel like you're being judged, there's a feeling, there's a sensation, and that leads to a lot of guardrails. So you're not able to treat that patient appropriately if those guardrails are up. Really, what we want to try to do, and speaking to what Anafer was mentioning, really try to bring the empathy into the room and see that patient for where they are. What habits do they have that they don't recognize? What cultures they live in which, there's so much food in culture, right? What cultural habits are they implementing, and are they doing it to an extent that it's causing them harm? Right? And then how do we approach that in a framework in which we can actually break down their day-to-day lives in a way that can systematically move them to their ultimate higher self, right? So when you start to implement some of these journals that are coming out, some of these articles that are speaking to the nature of public health, which I haven't heard you mention yet, Dr. Palmer. You have a background in public health. You are a public health expert, hence these conversations with you involved. But when you start bringing these articles and this research to the front of clinicians, when we start seeing how bias is affecting treatment, when we start seeing how certain treatments are actually having better effects than others, we're starting to get into not just these theories. We're starting to get into theories supported by evidential science that really show, hey, maybe we need to take a little bit more of a detour in this direction, right? Maybe we need to have more discussions around ultra-processed foods. Maybe we do need to have more advocacy in which our food supply is being more monitored or more regulated. Maybe we do need to have more policies in place that keeps certain restaurants, certain fast food restaurants away from schools, right? Maybe we need to look at this. And so I think that as more of these articles are starting to roll out, I think that we're starting to get that permission, that open atmosphere to really address the elephant that's in the room.
Absolutely. I mean, the advocacy space that you described there, right? Like if that's where public health is, all of us are public health practitioners. I acknowledge I am one. Is all of us as public health practitioners, I think two of the strongest levers that exist in public health are policy and advocacy, right? And you're describing both. I think education, of course, is naturally the third. And it sounds like clinically is where we're trying to emphasize the education. And then from a public health standpoint, also working on policy and advocacy and really trying to find ways to make sure that the exposure to certain things at certain times, like certain critical moments of development, I love that, right? Like there's foods we'd probably want to keep out of the schools. I think we could probably all agree that there's foods we'd want to keep out of the schools, or maybe quality of food that we'd want at certain times in development. As a pediatrician, the next leg of this I would love to see is the extension of ultra processed foods at different times of life. We know it's a dose dependent effect, largely what we see. I think that's why we see a lot of these diseases accumulate towards the later part of life. But we are also seeing just massive amounts of increase still in pediatric obesity, pediatric metabolic syndromes, other things like that frankly aren't yet connected to this whole framework. But as we increase our knowledge depth around ultra processed foods, I don't think anybody's going to go in with a pretest supposition that these are good for children. And so it's identifying the magnitude of harm and making sure that we are then again going back to like our advocacy roots here, which we all as providers in different ways hold like so dear. So I want to talk about the feature specifically. So in July 2026, the American Journal of Public Health, there's an amazing longitudinal study linking ultra processed foods to a significantly higher risk of dementia and cognitive impairment in older US adults. I find this study like really fascinating because our older, like going back to this idea of this being dose dependent, like ultra processed foods have really taken off in the last 20 years. The study population was 60, 70, 80 years old. And so their actual exposure is frankly probably smaller to ultra processed foods than maybe even like the three of us here from a generational standpoint. Like ultra processed foods existed when I was born. They've been kind of like sidelong with my nutrition the entire time I've been alive. I was a little concerned about it, about some of the implications here of like, is this a dose dependent thing? Is this something that maybe disproportionately affects the elderly? And maybe it is just ultra processed foods towards the end of your life lead to more rapid decline. I'd love to hear from you both on, like, kind of what are your thoughts on any mechanistic pathways? Like, why is this leading to the neurodegeneration? Recognizing that we're all just, this is going to be more correlation than causal probably for a while till we really figure it out.
I was telling Dr. Cox earlier, nutrition science is like being in the Amazon rainforest. There's so much going on. And I love that you just said, like, who knows about the difference between the correlation and causation with this exact impact on ultra processed foods, because at the same time, we're shorter attention spans with technology, right? Like we're living in a revolution that it's not just about our nutrition. We're working differently. We're always on a screen. Our TV is different. So it's going to be really hard to tease apart, but there are certain certainties around ultra processed foods where it's inevitable. Like you can't ignore that this food doesn't happen in nature, that this food has certain chemicals that are not nutritionally benefiting us, right? And at the same time, I want to give voice to the fact that we are living in an age of anxiety. And I have known that in my bones since I was a high schooler. And I remember the first time a friend of mine told me, high fructose corn syrup is bad for you, and all these things will happen to us if we have it. So I go to my pantry, and my friend and I are like digging through the pantry, throwing away everything with high fructose corn syrup, right? And that's just one ingredient. And right now, especially after I studied nutrition for 20 years after that, or 15 years after that, you learn it's not just one enemy, right? There's so many things that you can hear once you get interested in it, that everything is bad for you. It's not just high fructose corn syrup. It's not just the one red, I don't even know what it's called because I stopped paying attention about 10 years ago because my anxiety was kind of out of control. So how do we move on as consumers and as people who eat with grace and with a little bit of more peace, and still knowing, hey, this isn't good for me, but I need to live, right? At least that's kind of the extreme place where I, at one point in my life, found myself, and found that a lot of my patients also need that clarity and peace of mind. So how do we move on? First of all, it's not going to kill you. Like Ned said, dose dependent, right? So the dose makes the poison here. So how much of your diet is convenience foods? And if that much of your diet is convenience foods, we need to look at different things. Like, are you living in a food desert? Are you rebelling from your childhood where maybe you had a dad who only allowed you to eat vegetables and never allowed you to eat a processed food, and now this is like what you binge on, right? So there's so many factors. So what's going on where your diet is, a significant portion of your nutrition is not really nourishing you, right? And as far as the anxiety for like the parent, right? Intuitive eating really preaches, and gut health too, both of them really preach that you want diversity in your diet. Now, when you're looking at it from the lens of gut health, you're not thinking of ultra processed foods as a way to improve your gut health, of course. But if you can provide your children, or even when your child is inside you, with a variety of foods, more than likely, they will kind of navigate it very imperfectly, and it will take so much patience that I don't know if I could handle it, but they will navigate it, and they'll have these exposures that not a lot of kids maybe get. Like, a lot of kids might be lacking in exposure to fresh produce, right? Or on the other end of the extreme, exposure to processed foods. And so that's where we get a little bit more of like, then they're of age, and then they're like, what do I do with this new diet that was never shown to me as a kid? So that's not a perfect science, and I am not a pediatric dietitian, so there's so much more nuance within that. But I would say don't be terrified of your ultra processed foods if you are a parent, or if you are a provider or a consumer, but make sure that you're nourishing yourself in other ways. Make sure that you're eating fresh produce, fresh meats. And yes, when you're eating fresh meats and fresh produce, there's going to be science that's going to demonize some way that those potatoes are grown, or that meat is raised, right? So we can really put ourselves in a corner where it's better to just not eat at all. I've heard that from so many people. What if I just don't eat at all? Can I just take a pill, right? And the last thing I want is for people to fear food that much. And it does happen to where they're not eating. And let's go back to Dr. Cox's scenario where he skips breakfast, he has a quick lunch, and then on his way home, he wants that Chick-fil-A. I really feel that even without all the marketing, and even without talking about the chemical composition of these processed foods, a hungry person is less capable of making sound nutrition decisions. So if you are afraid of eating, right, because nutrition education is leading you to all these corners where you're like, I feel like I can't eat bread, I can't eat meat, I can't eat anything, right? My produce has pesticides, yada, yada. You're going to end up hungry. And when you're hungry, you're less empowered to choose a meal that's going to take you 30 minutes to cook versus the package that takes you 3 seconds to open, right? So, go upstream a little bit and say, are you eating enough? And I'll get off my soapbox now.
No, you're invited for your soapbox. Please don't. I have two quick comments or questions almost. One is I love the term convenience foods. I feel like that more than ultra processed foods is maybe something that like I can immediately identify. Can you help put a definition to that for our listeners?
I actually chatted with some dietitians before coming on this week, and it was really hard to define. I mean, it always has been hard to define. When I was in grad school, I'll never forget my director was like, all right, let's define processed foods. And it opened up this whole can of worms. And we're like, I thought it was so obvious what a processed food was, but it's not. So convenience foods, I don't know. I think of something that's shelf stable. It won't go bad. You don't have to cook it. It doesn't take extra time. You can access it at any gas station, or any vending machine, and you open a package. Or Stouffer's, microwave dinners, that's also convenient. But so is an apple, right? So yeah, it's hard. Convenience foods is really hard to define. I'll let you take a stab at it, Dr. Cox.
Honestly, this is one of the biggest challenges that are being mentioned today. So out of Brazil, there came out that in a lot of these studies, they're using this NOVA classification system. So I highly encourage our listeners to go and just research, just do a quick Google search of NOVA processing system, right? Or classification system. And you'll see them being broken down at least into 4 different categories. Now, it's not perfect. It's not perfect by any means. But right now, it's kind of the gold standard of what's being referenced today in a lot of the literature. So group 1 being those minimally processed foods, like Anafer was mentioning, those fruits and vegetables, raw meat, eggs, things like that, 1 ingredient. Group 2 would be more like the culinary, processing of things like vegetable oils or butter, things like that. Then you have your group 3, which are more like processed foods, like canned fruits or canned vegetables and baked bread. And then you got your group 4, which is usually the ultra processed, right? That's the soft drinks, the instant noodles, the reconstituted meats, the cured meats, things like that. Those are the categories that are seemingly becoming more controversial, that group 4. And so when it goes to that study that you were referring to earlier, Dr. Palmer, with regards to the dementia, right? So if we're looking at that study, I feel like one of the biggest things that came out of it was really the cognitive impairment, and Anafer, you were making reference to this before too, the cognitive impairment without dementia. I found that to be a very interesting category because I feel like each of us have experienced some form of cognitive impairment at some point of our lives, whether it's just feeling a little groggy, in the middle of the afternoon, or just, I got a good example. Maybe you just had lunch while watching a World Cup match, and you find yourself just waking up from this deep nap that you're just like, wow, I did not prepare for it. I did not realize I was that exhausted, but geez, what time is it, right? There's this, or even our children, right? Dr. Palmer, you and Anafer were mentioning how, we're starting to see a lot of these behavioral conditions like anxiety that are really kind of becoming a big issue today, especially since the pandemic occurred. So these little cognitive impairments without dementia, you can't put it into the category of dementia because they don't meet criteria for it. But I felt like this study showing 46% increase in those individuals who consume large amount of ultra processed foods. There's a significant thing to look at there. Maybe we need a magnifying glass over that. To me, I think the study made a little bit of a reference to some of those processed meats, like bacon and cured meats, that showed more of that association. And it doesn't mean like Anafer was mentioning, it doesn't mean that, I can't have bacon ever. I can't have my bacon and eggs, or my cream of wheat in the morning, like that. What's this gonna, how do I change my life? Like that's part of my identity. Well, no, you can. But if it's something that you're taking as like a prescription drug, when you're having bacon and eggs BID, or 2 times a day or 3 times a day, then it becomes a bit more of an issue, right? So I think that we have to look at the diversity of food, like Anafer was mentioning, right? We have to introduce that biodiversity for our gut health, for our mental health, for our physical health, and then you can even take that even further into spiritual wellness and so on. But we need to look at that diversity, because that will help us limit our exposure to the same insult over and over again. For example, alcohol, right? We talk about alcohol. We said there's no safe amount of alcohol, but we also talk about how we can't just basically tell people don't drink ever again for the rest of their lives. They're gonna be like, yeah, okay, doc, and then they go catch up with their friends at the bar to watch the FIFA game, right? I mean, we want to be able to connect with these patients. So maybe we shouldn't have 3 beers a night. 5 beers a night. Maybe we can regulate that. Maybe you can have like a glass of wine with dinner on a weekday, on an afternoon. So if we can try to just space things out, space out the insults or, some of these things that we know may not be good for us, then we can still have our cake and eat it, right? I mean, it's still okay, just in moderation. So I think that what our listeners really have to understand is that you don't have to eliminate everything. Right? We do know that there are certain associations that there's going to be findings for everything. Like Anafer mentioned, you're going to have that potato and someone's going to have an issue with potato because it's like, oh, now there's arsenic and lead in potatoes. I can't even have a baked potato. It's like, no, probably shouldn't have baked potatoes for breakfast snack, lunch snack, dinner, but space things out. And if we don't, and if we see that, we're getting those repetitive insults, then we're starting to get more into that education component that Dr. Palmer, you were mentioning. How do we make people aware that certain foods, maybe we look at Peeps, or I was looking at a moon pie at CVS the other day. I was surprised that I was like, wow, they still make those. I was looking, at mouthwash that has blue one in it. Okay, I guess mouthwash isn't this blue. I guess it shouldn't be that blue. And educating people like, hey, these are different sources in which you might get some exposure. Right? Doesn't mean it's unhealthy level of exposure, but there's some exposure. So recognize that and try to space it out with the diversity of your choices and what you put into your body and bring into the household.
I love that. Dietitians always like to think of food as what can I add, or what can you as the patient add to your diet, versus if it scares you to think I can't eat my ice cream anymore. Like, well, what can we add? Like maybe we have a meal too, so that your hunger can kind of tone down, right? Your body can respond with, hey, my glucose levels are higher. And then all your hormonal cascade says that ice cream isn't going to nourish me. And that's coming from your biology versus willpower. I love that you mentioned alcohol as well, because I got very fascinated with people's relationship with alcohol after learning all about relationship to food. There are so many questions I still have about addiction as well, and about our relationship to these things, compulsive behavior. But I will say I watched it myself. I dated this one guy who was an addict, and I remember he was like, oh, I can't get dinner until I get my cigarette. And I was like, I think you're hungry. This is the dietitian mind, but I was like, I genuinely think you're hungry. And, I told him let's eat first. And he was able to express to me, he was like, that feeling that I needed it really toned down when I ate. He's like, I think you're onto something, Anafer. And I was like, thanks. I've got 15 years of studying this stuff, but it is interesting because similar to what I was saying about you're more likely to stop at that Chick-fil-A and it almost feels like an impulse or something that you can't control. But when we're hungry, and also, what is your relationship to pleasure? And are you getting pleasure and play and exercise, right? So all these things that we can add to our life that can actually tone down that dial for needing that extra beer or needing that extra candy. So pleasure, play, exercise, and nourishment can all come at the bottom of that pyramid. And then the other things like a drink or peppermint patty or whatever you were just saying, the moon patties, they can come on top of that base, but you got to get that good foundation.
Yeah, I mean, going back to basic sciences, where Dr. Cox and I spent our first 2 years of this whole journey for both of us, I think of the advancements in the last probably 10, 15 years since going through those courses of the connection between satiety, right? Our increasing understanding of the importance of satiety orexin pathways, ghrelin pathways, things that link to then like your growth hormones, IGF-1s. And then, of course, how that's all tied deeply into your lizard brain at the dopamine context. The one other big thing that, we haven't quite mentioned yet, but is deeply tied to these is sleep, right? Increasingly, as we understand orexin, ghrelin, satiety, this very poorly understood pathway, even though we're starting to create drugs that act on that pathway pretty substantially, like the sleep, anxiety, feed, addiction cycle is all like tightly intertwined there. And so again, from a clinical context, some things that have really helped me to remove that judgment associated with that is recognizing how many other large, complex, and incredibly poorly understood things exist in this space as neighbors to disordered eating, disordered sleeping, mental health disorders, right? The more we pull these apart clinically, the less we know, increasingly, right? Even still with genomics and a rise of AI-driven data and better data sets and things like that, the more we know, the less we know every single time. And especially in these incredibly complex, Amazonianly complex things like food. And the other thing that I was thinking as you guys were talking about this is, there's an age-old adage, which is the solution to pollution is dilution. And so that if you are going to go have your moon pie, right? Like tie that to what Anafer is saying as a dietitian. What can we add to that? So you had the moon pie. Okay. We can't take that back out of the world, right? We're not going to ask you to be bulimic about your moon pies. What we're going to ask you to do is find other ways to add things either before or after so that you can kind of neutralize some of that, dilute it in a way. Dr. Cox, you mentioned moderation, which I think is a fascinating word, largely because I think this idea of moderation, I think it's frankly due for a rebrand. Because to me, when I hear moderation, I hear drink Budweiser, responsibly. Right? Like it was that moderation campaign as a result of many, many civil litigation suits that were brought against the alcohol and tobacco companies that they had to basically do brand recognition as moderation. It did nothing to curb the actual intake of alcohol, of cigarettes, of foods, right? But it massively increased the brand recognition and people's emotional engagement with the brand. Absolutely brilliant. Truly devastating to people from a public health standpoint, as alcohol, cigarettes, and food are probably the three biggest detrimental factors to public health in this country. So I hear what you're saying when you're saying moderation. I agree with you from a definitional standpoint, but emotionally, I go to a place where I like the diversity framework a lot better because they're the same thing, right? Like it's what you're saying is in moderation, you don't concentrate on one area. Very similar to saying like, we just want to diversify, add and diversify. To me is an amazing clinical framework that you could bring into a room to try to encourage people to be healthy.
Couldn't agree more, Dr. Palmer, honestly. And that's why I just love Anafer's viewpoint, because it's that diversity of the additions of different foods that allow for that moderation, right? The example that she used with one of her significant others who felt the need to have cigarettes with or food, by having the food, by adding that component, that toned down the drive for a cigarette. So that already allowed for a reduction in how many cigarettes are being consumed. Another example, because Anafer, when you mentioned that to me, I was like, geez, this does exist. Sometimes at the end of the night, I find myself like, oh, you know what? I like to have a beer, unwind, and, watch a little Netflix. And I find myself like, I'm actually kind of thirsty. Why don't I just get a glass of water? And I have a glass of water, and I'm like, I don't need that beer anymore. What is that? Right? So yes, I agree with you. Let's change the framework from okay, oh yeah, you can still, go have that Chick-fil-A in moderation. Go have those sodas in moderation. Why don't we add having more water? Why don't we add a snack between breakfast and lunch, or a snack between lunch and dinner? And then maybe that would allow for less consumption of whatever else that next choice is. And so I completely agree with you guys on that. I think that is really where we can flip the script and allow for ultimately the patient to reach their goals.
I found the same thing with alcohol as well. It's like once your needs are met, and sometimes it's a biological need like water, and sometimes it's an emotional need, right? And I never told myself I couldn't have alcohol. I've never done a sober January, but I have noticed my desire for more, or for that drink. During COVID, when my mental health was horrible, I had already built that relationship with my body where I was like, I don't think that glass of wine is what I need. And it wasn't out of a rule that I put on myself of like, you shouldn't drink wine. It was more of a like, I had built this relationship with how my body feels with different things that I was like, that's not actually going to satisfy what I'm really looking for. So yeah, like increase your toolbox, have a variety of things that you could do and see how you feel with different tools.
I think that the tool set there is something that, we often talk about from the clinical side of things in trying to like imbue our patients with these tools, right? Especially as we start to talk about like, how do you bring this clinically to bedside, right? Like we've talked about opening, setting the stage. What are some of these frameworks that we can be using in analyzing these for clinicians? But in reality, if I think about, like my brother in primary care, they've got maybe 40 slots in a day, 15 minutes. Your screening has to be laser focused and fast. Your ability to connect emotionally and empathetically also has to already be there to have a therapeutic relationship. So, what frameworks can we inject into these moments? Even going back to Anafer, where you opened up with, to even doing a quick, like sick or not sick assessment, something we're trained very commonly with. Sick or not sick? Sick, go see a specialist, or sick, recognize the limitations of what I can do. So like, what are some frameworks and tools that clinicians can bring into that room, into that encounter? Anything from screening, anything from interventions, diagnostics, like what can they bring on top of lipid panels and A1Cs that they're already going to have in front of them?
Well, first of all, we're talking about larger systems that are against us, right? We're talking about the food industry, and that's a system that's against us, but also the workload on a primary care or hospitalist, it's a systematic issue that the answer that I'm going to give you isn't going to be the most satisfying because it's in a system that is not ideal, to say the very least. So while we're talking to doctors, like let's advocate to change that, as we already are, as dietitians have always been advocating to change the food industry and the lobbyists and all that. But if you value nutrition and you're with your patient and you've got 15 minutes, right? Always start with a question. I want to say, how important is your diet for you, right? There's one question. Or how often are you eating convenience food? How much of your diet is convenience food? Another one, what's your biggest challenge when it comes to eating a healthy diet? A lot of people are going to say time, money, right? When they say time, that's an indicator they might be eating a lot of convenience food, or they might be skipping a lot of meals and really hungry and then eating a lot of convenience food, right? So start with a question, never assume. Also, don't ever assume that someone in a larger body is eating a lot more convenience food and soda than someone in a smaller body, because it's not always true. So yeah, I mean, it's really, really hard. Use your dietitians. Talk about this in your own clinics, right? Like in your clinics, in your hospitals, bring the dietitian to the table, be like, hey, I've got 15 minutes. What does this look like with our patient population? What are you seeing when we refer to you? Because in Aspen, Colorado, it's very different than when I was seeing patients in Houston, right? But I would have loved to be invited to the table in Houston with primary care providers or hospitalists and just having that conversation of like, all right, here's the dietitian's patient load. We're saturated. You can continue to refer to us, but if you really want to intervene, here's when you should intervene in your visit versus here's when you should refer to us, or something like that.
I got a couple questions for you, Anafer. I mean, because I think that it's funny. I'm hearing you speak and I'm like, you're so right. The system is totally against us. And that's, how are you going to, in 15 minutes, be able to dive into literally everything that we've talked about in the last several minutes, right? Obviously, it took us that long just to even have the conversation with our listeners. So how are we going to do that in a clinical encounter? Oh, by the way, the next patient's waiting. Like that's challenging. So I got a couple questions. One, do you find yourself and some of your peers using some of these assessments? Like I know that the CDC has like a barriers to exercise assessment where, the patient can fill out these questions and it will tell you, okay, it's a lack of motivation seems to be the issue. And here are some things to address that. One, do you find yourself using some of these, assessments for these people to kind of expedite the time? And then two, probably the one I'm even more interested in is, what changes do we want to see in a system where I can spend 15 minutes with one complex patient and I would bill the insurance company for the same amount of money that it would take me to spend an entire hour with a patient of similar complexity. So the system that you're describing focuses on seeing sicker patients in less time than spending more time with sick patients. So I'm curious about those two things. One, your assessment on, some of the intakes that you do, and then two, what system do we need to see, being implemented to help these patients?
So the first question is about my screening and assessments that I use. I've never used any of those tools that I've been provided as a dietitian, and I don't think I am better for it. I just think that I operate differently, and that's not my strength. I think there are likely dietitians who do use those tools, and maybe that is their way of getting to where they want to go. And I think we need a variety of different dietitians practicing in different ways. I use like a lot more of a counseling style of like, let me get to know you. And here's where my gut tells me I should like start asking. Good or bad, I don't know. Probably not ideal if you ask my masters of public health, like professors. And in terms of what changes we'd like to see in the system, I think there are going to be way smarter people in the room who are going to have to put their heads together to figure out how we're going to combine capitalism and healthcare and do it in an effective way. That's so hard. I've got so many friends who are doctors and surgeons and vets, like veterinarians, right? For my dog, like we're all up against this money industry that we all work in. And yet it's not that it doesn't align with our values. It just sometimes competes with our values to help the patient or the dog. So, I mean, these are way bigger ideas that we can record another podcast on just talking about it, but I don't believe that I have the solutions. I want to believe that there are smarter people out there who do.
Well, I believe that you're incredibly intelligent. And what I gathered from that is that when it comes to assessments, they can lead to, the patient feeling like there's already some bias, right? If you're introducing a questionnaire that's saying, what are your barriers? They're going to be able to tell from the questions that you're being assessed for their barriers to exercise. So that could be off-putting. So what I'm seeing is that you take more of a personalized approach by just having the conversation and starting it that way. And then as for our systems, I mean, yeah, you mentioned it clearly. I don't know if everyone's aware, but we're starting to see research popping out where we have a lot of private investment inside of healthcare, a lot of venture capitalism inside of healthcare, and we see that the outcomes are worse once that venture capital starts making its way through. So we are in need of a new system, especially as we're starting to see reimbursements starting to decline inside of a structure that really does harp on seeing sick patients very quickly.
Completely. I think, Anafer, what you mentioned about like keeping it local, bringing in the teams that you have available is a great first step. So who else is in your, every clinic has some multidisciplinary component to it, right? Even if it's nurses, MAs, like other people with a diversity of degree types. If you're in actually a multi-specialty clinic or you're in like a larger mixed medical surgical clinic, which then often does have associated like, dietitians or people who are more affiliated kind of like with you, Dr. Cox, on the lifestyle side of things. Like it's just getting those groups together and starting the conversation is always, as a maxim of public health, it's always start the conversation, right? Get people thinking about it, get people talking about it in the communities that you can and let it be focused on your community. I think they'll feel better that way. You avoid that sense of what you're describing, Dr. Cox, of that like implicit bias in some of these surveys that we get. The CDC is great, truly a wonderful organization. I couldn't think more highly of the CDC. I have family members who've worked there for decades, but they design things for 340 million people. That means it's going to work in Houston. It's going to work in Aspen. It's going to work in Loma Linda. It's going to work here in Detroit. That doesn't mean it's going to work great in any one of those, but it is going to work in every single one of those. So there's something kind of wonderful about something that works everywhere. But does that mean that it's the right tool? And what can we create that's more local, that's more specific to the patient population that we serve? Listeners to this know that I often, like one of the other places that I work is very frequently on a Native American reservation. completely different cultural cultural components, completely different access to food and nutrition, completely different sense of what a food desert truly is. Like all of those things bring this like hyper locality to something as essential as food to the conversation, where I actually really genuinely believe, what you described, Anafer, is brilliant. Like it has to be grassroots in a way, as opposed to something like that starts top down from the Center for Medicare and Medicaid Services, right? Where they push out some new, frankly, it's going to be a biochemical test, right? That's what they're going to do. They're going to do the next version of metabolic screening instead of something that's truly local and actually works for your community.
Brilliant. Could not have said that better at all.
Well, look, we're building towards. I don't want to get too far over our skis here, but we're building towards this third session together, where I actually really am excited to talk through what at the advocacy level, at the systems level, can we do? Because I often feel that same frustration that you described, Anafer, of like big systems, like big monolithic systems, are in tension with one another. Maybe not purposefully, but they're certainly not incentivized to necessarily be aligned. Again, all three of us work in public health. If we've seen anything in the last 6 years, like we've seen the erosion of public health as an ideal. We've seen the erosion of public health from a source of funding, from a source of financing from the federal government, or even from like a source of focus even. So these big systems are shifting, they change over time, they respond to macroeconomic and frankly, administrations that change and bring in new values and mores to this. But that doesn't mean that we're left without solutions. It just means that we go back to what are the pillars of true like change. Right. And often grassroots can be just as powerful as top down. Often you can start with those same pillars of advocacy, policy, and education. And those are all things that like we're really going to dive into and sink our teeth into on the next one. So last questions for both of you to round it out. So we're going to start with Anafer. If there's one systemic change that after reading the American Journal of Public Health and the Lancet series that you would want to vocally support, what would it be?
The one systemic change we can definitely advocate for is subsidizing real food versus just the corn, the wheat, and the soy.
One of my favorite, way back in med school in northern Michigan, there's a program where they doubled your SNAP dollars if you used them at a farmer's market. So SNAP, WIC, EBT, it was a brilliant, brilliant program. And it was community-led. They obviously, the federal and the state government weren't doing that. But it was community-led. And it was really, I was like, immediately, even as a med student, I was like, yes, that is the right incentivization. That's municipal investment into the community of where food's being created. It was one of my favorite things. So what you're describing is near and dear to my heart. So, all right, Dr. Cox, as a learner today, learning from Anafer, what's the very first thing you're going to do to change about how you approach nutrition counseling in your clinic tomorrow?
Can I answer by saying getting Anafer involved in my practice? I mean, is that an option? I feel like she had so many great things to say. And so it's really, for me, one of the things I really want to take home is really trying to introduce more to help people increase diversity in what they're consuming. I have patients come in, they say like, I think my problem is that I don't eat enough, but how can I eat more when I'm struggling with overweight and obesity? Like I can't and it's like, oh well, we do need to eat more because like we said, you're skipping breakfast, you're skipping lunch, and you're darting Chick-fil-A after work because you're tired and hungry. And as we've already discussed, when you're tired and you're hungry, it's harder to make challenging decisions, right? There's another saying: never go grocery shopping when you're hungry. I don't know if any of you have done that, but I just walk in to try to get a handbag, and that sucker is like, oh, I probably should got in the cart, So I think I would like to try to focus more on introducing foods to help people moderate some of the more addictive foods that may make it into the diet. I think that's what I'd like to take out of some of the conversations today and start to implement right away.
I love it. Replacement therapy. It works for methadone. So I think it's fantastic. I want to thank you both so much for coming on the podcast for Doctors by Doctors. It's been truly wonderful having this conversation with you, learning from you both. We hope our listeners did as well. Thank you again for joining us.
Thank you so much for having us. That was really fun.
Always a pleasure, Dr. Palmer, and Anafer, just as much of a pleasure.
Thanks for joining us this episode. You can catch the podcast For Doctors by Doctors on Apple, Spotify, YouTube, and all the major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. As always, thank you for listening. The next time you see a doctor, maybe you should prescribe this podcast. We'll see you next time.